Thank you so much for inviting me. I'm actually new to shoulder surgeons because my specialty is hip and knee arthroplasty. But I'm going to talk about my experience in PSI and how I managed to transfer this with the help of Dr. Pascal to the shoulder surgery. Um, this presentation and the experience actually was gained from 3 centers that I worked on abroad, starting with my experience in UK, especially at Leeds University, where I did my MD and I developed the PSI starting from 2001. And then working in Pittsburgh in US and Toronto University, and then back to Egypt here at October 6 University, where I'm working now. So this is a collective experience now from these 4 centers where I'm going to present. Initially, robotics came first as a computer-assisted tool before the PSI. And this is amazing because robotics in orthopedics started in 1992, actually published in 1992, which means that it was used in 80s. In 1992, the first paper appeared in Clinical Orthopedics, and related research was using a robot for hip replacement. And what's strange about here is that you're starting with the most complex technology and then moving from robotics to navigation, which is less complex than robotics. In 1999, started the navigation, and actually I attended the first symposium where they had a live surgery for knee replacement by navigation in Tuttlingen in Germany, and this was the first when the first navigation appeared to be used in orthopedics, at least for knee replacement, because it was used before for neurosurgery and spine. So moving from the complex to the easier and user-friendly is the PSI, which came, I started in 2001, but actually it became in practice in 2008. And the reason for that is that something called 3D printing machines. The one on the left-hand side is a rapid prototyping machine. This is the name for it, and this is a complex, very expensive. It's equal to probably 500,000 sterling pounds. The one on the right side is a desktop machine, which came into use in the last 7 or 8 years, and this becoming now 500 pounds rather than 500,000 pounds. So it's 1,000 pounds less, 1,000 times less. Okay, so what this 3D printing could do for us in surgery, including shoulder surgery, they could print a model. So if you have a complex shoulder where you have bone defects, problems, or tumors or whatever, you can print just only the scan. Or you can design a guide that can help you in positioning glenoid component or making the cut in the humerus. Also, you can design an implant like special plate and screws, like what they use in maxillofacial. And at last, you can print like a custom-made implant or even a graft. You can see here like a tumor in the mandible. Half of the mandible could be removed, and then you can have an artificial material printed by the 3D based on the CT scan or MRI of the opposite side. So one slide about the history. When I started the patient-specific, I called it at the time patient-specific templating. It was a novel technique where I replaced the complete instrumentation system of the knee to be only 2 pieces. And this was published in Clinical Orthopedic Related Research in 2006, where I presented 45 experimental total knee replacement. We did not have any equipments like robots or navigation, just only a specific software on a PC and design the jigs and so with this amazing technology, how you can replace all these amount of instruments and also do the planning so that you don't require to enter the medullary canal. So how did we transfer this into shoulder? Actually, we have a problem in Egypt here, is that sometimes the stock of the implants could be missing. And we face this almost every time with hips and knees, that some of the sizes could be missing. So when we have a planning and we know the sizes beforehand, it makes it great. And this is something that Dr. Bassem Flega is also interested in sorting out this by having the planning at the start so that he knows that everything is available beforehand. So the collaboration with Dr. Bassem Flega started several years ago. And he gave me the parameters for the design that required to be done for the humerus and for the glenoid. And our team worked on this and developed the guides for the humerus and for the glenoid. However, we are not the first to develop PSI for the shoulder because Professor Ainati from Cleveland Clinic, they developed this first and they published this, or also they have patents for it. And also other companies, implant companies, they develop the PSI. So with the PSI, basically what we do is just we do a CT scan of the shoulder. You have the humerus, you have the glenoid and scapula, and then you can make planning for the surgery and simulation, measures the sizes, design the guides that's going to sit on the glenoid and the humerus, and eventually print these guides to have it as a physical models that could be sterilized and used during surgery. So this is a design of the glenoid. You can have it according to the company. So if we know the company beforehand, then we design the component, the guide according to the shape of the component. This is the one for the humerus. Our humerus guide actually is unique because there isn't, at the time when we developed the humerus, there was no other companies that has good humeral guide for shoulder replacement. We were the first and we have patent for this. So we have the shoulder here. There are several designs in the market with many other implant companies. I'm not going to go through this, but just only this is one of these examples. This is what we do for the knee. I'm going to skip this one. I mentioned about using the 3D printing for designing patient-specific implants. Also, you can use it to design a patient-specific spacer, whether you have an infection or you have a tumor like this case, then you can design a guide where it can help you where you get your cut with the safety margin and you know where is the level of the tumor. And after you do the cut, then you can use the spacer, which is patient-specific, preparing for the second stage when you need to use a patient-specific implant or you use a tumor implant. Here is a case with a fracture that required anatomical total shoulder replacement. This is the planning with the sizes. Here you get many screenshots that you give to the surgeon for the bone and the dimensions. And these are in different planes. As you can see here. So you can have as many screenshots as you want, which will help you during surgery, especially when you have extensive osteophytes or bone defects, then you know where these are placed. And also you can assess the quality of the bone. So by doing a finite element analysis, you can know where the bone which can get the pegs or was a required reaming or not. Here is a humeral guide. This is a second case was a total shoulder replacement for a patient who had a fracture fixed by plates and screws and then developed osteoarthritis. During this planning, you can see the dimensions of the bone and also the glenoid and the distance for reaming. And this is very important because not every glenoid has got a good bone stock. So some of them may require very minimal reaming or no little reaming. And that's important to identify this beforehand. Here are the dimensions. This is the design. And this photograph for another case, which was done by Dr. Bassem Flega, where the humeral guide is positioned, and then you can make the cut on the top of this guide, and then you can maintain the required inclination of the cut in the coronal and sagittal planes. This is a very interesting case which was done by our team in October 6 University Hospital, where we had this patient with a fractured glenoid, which had malunion and the defect and the deformity, as you can see here. So you can see the defect here is really massive. And then you have the glenoid lost its normal configuration. So it is not a cavity anymore. And you have two surfaces here. So it's very difficult to do this when you go for surgery, because you wouldn't be able to know where you position the peg and on which surface you lean. So unless you know which part is the normal anatomy and which part is the normal one, that's very difficult. So you can notice at ease when you do the planning while the patient sitting at home, but you do the planning on the computer, and then you can design the guide that's going to help you to position. And this is a guide in place with the surgery done. Thank you so much. I look forward to your questions.